is just to introduce you to the panel. We're going to have two moderators. I'm going to request that they come to the floor. This is going to be a session, as you know, very relevant and challenging as well, I'd say, because it's going to be talking about innovation for the integration of management of communicable diseases and non-communicable diseases in priority programs in primary care. And it is going to strengthen our primary care. In this panel, which is going to last around 2 hours, as I said, we're going to have two keynote moderators. We are privileged to have the Director of Departments of the PAHO, and we have Ansel Hennis, the Director of the Department of Non-Communicable Disease and Mental Health in Washington. And he's going to moderate the first part of this session for 1 hour. His answer is very important that we're going to try and stick to the time up till 11:30 more or less, and then we will continue with the second moderator and the second component of the session, which will be moderated with a keynote by the Director of the Department of Prevention, Control and Elimination of Transmissible and Communicable Diseases, Sylvain Aldigueri. Welcome to both of you, and to ensure this is going to work properly, I'd like to encourage the colleagues who are going to be on the panels, if they're already in the room, Cristian Herrera and Dr. Hugo Godoy and Dr. Gabriel Paredes. I would like to invite them to join the panel. And also, they're going to be here for 2 hours, but also going to invite Dr. José Anton Montiel Britos, who is going to be with us if he's in this room, and Dr. Leandra Abarca. I'm going to encourage you to take a seat. Again, welcome everyone to this session of this challenge of innovation integration of communicable diseases and not communicable. So, without further ado, Dr. Hennis, the floor is yours. Good morning, everyone. My name is Ansel Hennis. I'm Director of the Department of Non-Communicable Diseases and Mental Health of the PAHO. It's a pleasure for me to be in Uruguay and participate in this forum, a regional forum for Alliance for Primary Healthcare in the Americas. It's a pleasure for me to welcome you to this session about innovation and integration of the management of communicable and non-communicable diseases in primary health care, and see our three panelists. We are waiting also for Dr. Pereira. Dr. Gabriel Paredes is Dr. Paredes is from Honduras. He's a general physician and in management of services. He's a regional director of the Department of Santa Barbara, and he leads integrated primary healthcare services, and they were chosen for the program for strengthening primary healthcare as a project or a example project of integral project and systemic to improve the quality of life and access, universal access to health in the population of Santa Barbara. And Dr. Hugo Godoy is also a physician with a MBA in economics and healthcare management. He is currently a specialist leader in healthcare. For the last 11 years, he's been working with the Inter-American Development Bank. We are now going to begin with a presentation from Dr. Paredes. We have a video. In all corners of the country, Secretary of Health, with the accompaniment of the PAHO, is implementing a key strategy to strengthen the teams of family healthcare, a group which includes doctors, physicians, auxiliary nurse, promoters, and other healthcare professionals. The SFAMs work as a united team, taking important services directly to the homes, communities, and schools. They represent a solid commitment to build a healthcare system which is fair and accessible to all. Through this model, we can come to all those people who don't have an access to the health centers and or healthcare places. In this case, we do a mapping to try and use the community resources, the leaders who know the reality and know the zone exactly, the geography of the place, to represent it more precisely as possible, to be able to establish a map of the community or their community and be able to differentiate the different population groups of those who we want to reach with the family healthcare team. This way, we're going to try and give good services. What I'm going to do is update your documents and say who lives, ask if they work. These teams are key for the management of non-communicable diseases. Currently, we're divided in 3 SFAMs, and each one has their work area. We work with 5 villages which are visited with the responsibility of San Marco and the urban area, and each doctor has their promoter and a monthly program to do the home visits for the patients who come to the club and those who may need a follow-up, or for those patients who have private healthcare. We see a lot of chronic patients, diabetics, high blood pressure, and they have different complications, and they often don't adhere to treatment. So we explain the risk factors and the alarm red flags so that they can implement treatment in time. And if we see any of these flags, will be transferred to the adequate place. Whether if it's a complication in a diabetic patient, they often sent to Catarino Hospital or Santa Barbara, or the hospital where they have more accessibility. It's a patient who's been very responsible with her antenatal controls, but in her last trimester, we managed to notice that she had edema in her lower limbs, and it's one of the risk red flags for. And every Tuesday of the month, we control and we do the follow-up. We see the flags that could come in a pregnant woman, and it may be indicative of preeclampsia, and that could complicate the pregnancy of this patient. And so we give her instructions, control her blood pressure, some exams that are going to be prescribed, and then the next control for, in her case, to follow up very closely.
We want to improve access to services. Historically, we've had sectors in our society that haven't had the opportunity to have access to the services that we provide in all departments all along the country. We've seen the opportunity, and we've identified pregnant women at risk who hadn't had the opportunity to get to a health care center, and we've made it possible for them with chronic diseases, because of economic situations, have not been able, or it's difficult for them to get to healthcare centers. And so we have shown that it is possible to identify early all problems of society. We're going and moving through a healthier Honduras, and we want to ensure that healthcare gets everywhere, complying with the fundamental purpose of healthcare for everyone and everywhere. Good morning. Thank you. I would like to thank the panelists and the colleagues and all those of you. It's an honor for me to be able to share with you the experience that we have lived in our department in the country as well. And I would like to thank the chairperson of Sala, Mr. Minister, for awarding this responsibility, and PAHO for their constant support at this stage of the health care of our department. Primary health care is no doubt the key to solve many of our elementary problems at community level and at country level. The communities and the families are the basis of our society, and that's where problems arise, fundamental healthcare problems that end up being more complicated afterwards. The first and the primary health care is the gateway when the population has health problems. And it is this tool that allows this primary health care the possibility of dealing comprehensively with all the problems that the system may have. Our experience in Santa Barbara has been very interesting. You've been able to see it in the video. It's a strategy of a plan that is being developed at national level. The strategy or the priority is to strengthen the primary health care through SFAM. When we arrived at Santa Barbara, we faced a situation because the service that was being provided was in most cases in 28 municipalities of 500,000 inhabitants, was just healthcare. All the teams, doctors and nurses were providing healthcare to any spontaneous demand in 93 centers in all the department, between comprehensive healthcare centers and WAFs, which are primary healthcare. Now, this plan involves different components. They allow us to deal with healthcare at primary level in a cross-cutting manner. We've been chosen as the department to show that this project is going to be successful in our country. And we've had quite a successful experience. These components in dealing with non-communicable and communicable diseases, surveillance of public health in general, and information system, particularly strengthen capacities of the teams, has been very important. As I mentioned earlier, activities were just for healthcare, and what we are doing is changing our strategy with which we are dealing with health problems. Now, SFAM gives us the possibility of reaching out to communities, reaching out to families, and being able to make a general diagnosis of families, not only of those who are ill, but all those who are at risk. Also valuing the circumstances of their houses, how they live, their income, the communities, what services those communities have, and then make a general diagnosis of what could be affecting the diseases that we could see. As regards chronic diseases in our department, for many years we had been dealing this in a primary healthcare, we were only receiving the spontaneous demand, and then referring to the second level, which is hospital, we couldn't reduce the load, the workload. We were always receiving requirements more and more. After the pandemic, we could see that chronic diseases were increasing in number. There was a demand of patients who were insulin dependent, and that grew significantly beyond the capacity we had to obtain insulin. So it's not a question of buying more insulin. It's not a question of buying more medicine for chronic patients. It's trying to avoid at least those who have already been diagnosed with these chronic diseases to be able to be treated adequately to prevent any complications that generate the highest hospital costs. In the case of families, and it's important to work with families, we have to identify the children, those who are at highest risk, could change their lifestyles in order to avoid diseases to appear, because in some cases they will, but not as it's happening now. We have younger people being ill. We could say that there was a father or a mother that had a chronic disease, and it was when they were 50 or older. Now we can see that there are people who are 35 years old are already having pre-diabetes, pre-hypertension, and so on. Now, family healthcare groups are not only educational or promotional teams, but PAHO has provided us toolkits to the team, which is a multidisciplinary team, a doctor, a nurse, graduated nurse, and a social promoter. They work together, they make a comprehensive diagnosis by family and by neighborhood in order to identify each one of those who are ill. If they are, women are pregnant, if there are communicable diseases, a comprehensive diagnosis. In that way, we have inputs, and the municipality can be coordinated to generate strategies. I fully believe that managing healthcare must be managed. The decision-making process of strategies must follow a national plan, but at national level there must be a decision-making capacity, because communities change from one place to the other. The conditions change. In some cases we're going to see some diseases, and in other places we're going to see other diseases. And so these family teams are not only paying visits and producing diagnoses, they can make primary interventions so that they can be referred to the closest hospital and make more, or healthcare center, and make a more adequate diagnosis. This is just to understand what's happening in Honduras, which responds to this plan, that is to provide primary health care with a different approach. Thus, progressively, we can intervene in the places where all these problems are occurring and reducing the load of these diseases. In 2014-2021, PAHO made a study where 15% of hospitalizations were of diseases that could have been treated at primary healthcare, and we are diagnosing that at a later stage. We are looking at chronic diseases of people who had been suffering for 15 or 20 years. And this is precisely what we are trying to intervene in order to be able to reduce this load. The development of information systems goes hand in hand with all this. We can have a more generalized information, standardized population data, and of all the system. And also, we are trying to implement the telemedicine project. That way, hospitals may be linked to the primary health care so that people can come down from remote areas for internal medicine consultation, where it would be threefold cost, but to have a control consultation or appointment. So in the closest center, the chronic disease could be followed up with a specialist in a remote manner. medicine. How are we dealing with it at the primary health care? Well, our secretary has made strong efforts to provide every healthcare center. We've been working at regional and central levels through the rotative fund with which the Secretariat works in order to have provisions permanently. This is an enormous challenge because chronic diseases are more and more and demand more and more medicine. We don't want to spend millions on medicine, but to look at strategies that can give long-term results in a sustainable manner. We have to establish them as strategies that are permanent for countries, not just a project for a certain time, but we must start working constantly. Yesterday, I was very pleased when I heard the experiences in Brazil. We dream about having our population a healthy population. Not that we don't have hospitals to treat people who are ill. The idea is that they're not ill or that they are ill as little as possible so that they can be productive, that their families can be safer and secure. A family with a father or mother who is ill is a family that has an uncertain future. Our roadmap in relation to the preparation of an IT system, digitalized system, is something that the Health Secretariat has been doing together with Sala and the IADB. We hope to have all our IT system to one single system so that we can have access and a tool in our computers to make an analysis of all the data and make the right decisions at the right time. The management methodology of healthcare is a very important tool for his families, not only to send them out to work, but to look for a way whereby these tools can be result management so that those who are working extensively do a fundamental fundamental work. Obviously, people will continue showing these diseases, but they have to continue making that transition process where community and family work must progressively increase so that progressively we can reduce the workload of chronic and non-communicable diseases.
Thank you very much, Dr. Paredes, for your presentation. Now,
an overview of the PAHO initiative on strengthening integration. I didn't do it. On strengthening integration of entities in primary health care. My presentation will be, my slides will be in Spanish and I will speak in English. We can begin. Excellent. I can change. Wonderful. Okay. Oh, okay. Excellent. Thank you. So basically, we are all aware of the 5 principal non-communicable diseases: cardiovascular, chronic respiratory diseases, cancer, diabetes, and of course, mental health conditions, particularly suicide. And of course, the major risk factors, which are consumption of tobacco, alcohol, unhealthy diets, inadequate physical activity, and air pollution. Now, this gives a perspective on the mortality. And this is comparable, so I'll focus on the Americas. There's 7 million deaths annually, of which 81% are due to NCDs. Of these deaths, 34% occur between ages 30 and 70. In other words, these are the premature deaths, and these deaths are eminently preventable. And it's our role, our challenge to reduce the premature deaths. from NCDs. Now, this slide speaks to the principal cause of death in the region during a 2-decade period. And as you can see, the principal cause is ischemic cardiac events, followed by cerebrovascular events or strokes, followed by Alzheimer's and other dementias. Many dementias other than Alzheimer's actually are driven by the risk factors for NCDs. Then we have chronic obstructive lung disease, respiratory infections. Other NCDs include diabetes, except from renal causes, etc. So basically, of the principal cause of death, the vast majority of NCDs, as you can see, as you follow down the graphic, and they're all in blue. Now, this is the unconditional probability of dying from one of the 4 major NCDs in the Americas. As you can see, the men are in green, the women are in red, and the average is in the middle. And what this slide basically says, projecting to 2030, is that we will not reach the targets in terms of reduction of NCD mortality. In fact, of the 194 WHO countries, only 14 countries will reach this target of reducing premature mortality, and only of the 14 countries, there's only 1 country in the Americas. So we have a long way to go to achieve this. And this is why we need to work even harder. We heard from Dr. Paredes about the importance of prevention, early detection, et cetera, et cetera. And we also have to tackle the risk factors and improve treatment. Now, what is the evidence that improving treatment works at primary care level? And this study here was done in the Kaiser Permanente system in Northern California. And what you can see in the blue, the top graphic, is the control of hypertension in the Kaiser Permanente system compared to the rest of California in the tan, and the national rates at 64% in California. And what they did was that they implemented a system based on a hypertension register, which is comprehensive. They measured performance at the level of the clinics. And this was quite transparent. They fed back the results of blood pressure control to each clinic so the doctors knew how they were doing. And if they weren't getting control, they referred on for secondary and tertiary care. Then they had a treatment algorithm whereby they used set drugs, 3 drugs, and they treated in a stepwise approach. And if it didn't achieve control, they referred onwards to secondary and tertiary care. Then they did some task shifting. So the doctors didn't measure the blood pressure. The nurses did. They're much better than the doctors are. Plus the doctors get the patients anxious and blood pressure goes up. And of course then, they use standard medications, which was a fixed dose combination pill. And what that meant was rather than taking 2 or 3 pills, they took 1 pill. And with all of these initiatives, they were able to show blood pressure control at 90% during the period of observation. And what did improved blood pressure control translate to? This. So the heart attack rates in the system fell quite dramatically over the 13-year period, particularly the heart attacks due to ST segment elevation. So there was clear linkages between improved control and reduced mortality. That's the basis of how we developed the HEARTS program. In the world, there are 1 billion people who have hypertension. That's 15% of the overall global population and 30% of all adults. In the red are those who don't know they have hypertension. Tan, those who have hypertension not in treatment. Yellow, hypertension in treatment not controlled. And green, those who are in treatment are controlled. And this is a snapshot across the region. The best control is in Canada. They've had a program there for 30 years in blood pressure control and public health initiatives, etc. The worst control is to your right. And really, this is a marker of how successful the programs are. Hypertension, treatment and control is the major factor that reduces premature mortality from heart attack and stroke, the major killers in our region. So this led us to develop the HEARTS initiative. It shows based on lifestyle changes, evidence-based clinical protocols, medications and health technologies, multidisciplinary teams, and that's exactly what Dr. Paredes said too, the importance of treating NCDs with multidisciplinary teams, and also monitoring systems. And these all came through in what he was doing in Honduras. And this really takes us now to the initiative for strengthening hypertension management in primary care. And as you see over on the side, on your right side, the block that looks at management of cardiovascular risk and hypertension, this is exactly what HEARTS is. And this is taken from the WHO PEN package. It also includes health promotion, education, tackling cancers that can be screened and managed in primary care, for example, cervical cancer, screening for breast cancer, management of respiratory diseases. 15% of our youth and our young populations actually have asthma in this region. It also speaks to management of diabetes and also education, etc. So this really gives you a perspective of the scope of what we're doing in this initiative and the basis. So it looks really at the primary healthcare assessment strategy. These are the processes that, in terms of strengthening the health infrastructures, quality of care, increasing access, the whole issue of equity falls into line there, as well as improving the quality of care. And these are the different elements of what we need to achieve in this process. We have made the definitions in terms of strengthening the integration of NCDs in primary health care, which is the detection, diagnosis, and treatment and follow-up of NCDs in an equitable system integrated into the care system at the different levels, the subnational, the local, and the national level. Also in terms of really strengthening the management at the primary care level. Also accelerating the integration of NCDs in primary care. And this is built around a focus of equity. There are many who never get access to care because they're beyond, for whatever reason, be it they live in remote areas, and we heard a little bit about that in Honduras, be it that they come from populations that are underserved or populations in vulnerable conditions or discriminated against. And the issue really is to get these high-risk populations under the umbrella of the healthcare system. So the idea is to increase equitable access, and it means implementing integrated services for NCDs, increasing the capacity for service at primary care level. And this also includes the fact that people at the primary care level who are not controlled or managed need to be referred for additional treatment. So it speaks to referral and counter-referral at higher levels of the health system. So primary health care is the foundation. We must get this right, but the health system is not exclusively primary care either. When people need more than primary care, they have to have access to additional care. And then also another key element is collecting data and information to assess how you're doing. So these are the strategic lines of the PAHO initiative, Better Health for NCDs. So it speaks to, number one, developing operational plans to amplify and expand the services at the primary care level. And so this means working with countries at the sub-territorial level, the subnational level, to do situation analyses and to build roadmaps for how to integrate and how to scale up the quality of services. Outreach to communities, as I said before. Also building the whole issue of normative guidance. We looked at the current guidance that exists in the WHO documents, the PEN package, and we've recognized we need to update much of the information to be current in the 21st century. So that's another element that we're now working on, developing workforce development, health workforce development. I see my colleague nodding because he's in charge of that element. And it really means assessing the healthcare workforce and also improving training, et cetera. And this is a major issue in our region. Also, the access to medications. We heard a little bit about that from Dr. Paredes. And the PAHO revolving funds. Increase access, cost-effective access to medications. But there's very little uptake, which is really very unfortunate. So we're looking at how to bundle NCD care to make it more accessible and appropriate for member states, and also measuring information systems to know how we're doing and to get outputs. What we found true is that without working facility-based information systems, no one knows how we're doing. So we have the inputs, the outputs, and the outcomes. And this is a detailed slide, but really what we hope to achieve through this process is improving blood pressure control, diabetes control, fewer emergency room visits, and ultimately to reduce the mortality due to NCDs and improve universal health coverage. This is the QR code for access to it. Thank you so much. I'm actually going to call my colleague and collaborator to the podium as well, to the head table, Dr. Christian Herrera. No, come right up, Christian. And he is a colleague from the World Bank. Yeah, please. So let me, right, so what we'll do then, we will have a few issues. So everyone has seen the presentation from Dr. Paredes and also my presentation. So I'm actually going to begin with Dr. Hugo Godoy. And Hugo, I think what I'm going to ask you to comment on really is that the Inter-American Development Bank really does a lot of work in terms of NCDs, in terms of strengthening NCD health systems and services. You've done a lot of work with us too in terms of information systems for health. So my question, how can the IDB facilitate some of the work that I've described to you, the PAHO initiative to strengthen NCD care, better care for NCDs at primary health care? And could you share any projects that the bank is doing in terms of NCDs in primary health care so we can get a perspective of what the bank is actually doing?
Hola, gracias.
Thank you. The bank has been working with many countries for many years to try and support primary health care, especially with the management of non-communicable diseases. So, for example, in Argentina, there is a long-standing experience of the process of early detection, treatment, and management of chronic diseases, with an important innovation in relating all these interventions with financing. We have good experiences in this case, especially also in Brazil. We've been supporting Brazil in specific interventions where they are trying to improve the management of chronic diseases. In Central America, we also have a project which is quite ambitious at the time of trying to improve in El Salvador the management of chronic diseases in the primary healthcare level, and also a management in a network until the building and construction and functioning of new specialist centers for chronic diseases.
The same applies to Honduras. This is a good case to create alliances. We've been doing this for quite some time. We've supported family health teams. PAHO is starting this support in Santa Barbara. We didn't have these teams. And now we have made 263 family teams in different departments in Honduras. And we also have other elements. I would also like to mention some issues like these. In the first place, the importance that we grant due to our experience having human resources in primary health care. I think that Dr. Paredes also referred to that. The most important thing in primary health care is human resources. There are many governments insisting a lot on trying to build healthcare centers, and sometimes resources aren't enough. But the most important resource is human resources. We've seen the experience of Honduras in this case. By family healthcare teams, we've been able to move forward with communities, with technology and innovation, which is most important. Um, we can improve access with a health team that could be, in this case, approaching the communities patient-focused. In the second place, I'd like to underscore and taking as a basis the experience of Honduras because it's the one that's just been shown here. All these health teams, in this case the Honduras team, going out to communities, map the community and identify and characterize the individual risk and the population risk. And this is most important because this is a territorial and populational approach, which is important, and also the responsibility of taking care of the health of this population. And I think that's important because usually governments have had a lot of experience. It's not that it's bad. I think it's important. We've also only focused or mostly focused on hospitals, but these teams, since they are low cost and they're cost effective, they can improve the health of the population if they can be built adequately, identify risk. And what I mean by identifying risk, when mapping, they can identify where the high tension people are, or the newly born, the pregnant women, and they make an individual plan for each one of them and a follow-up effectively. I'm going to refer here to the question of integration because this is also one of the items in this forum. Dealing with chronic diseases and also communicable and non-communicable diseases in this population territorial approach to be able to characterize population risk is important, together with individual characterization of risks that people run. In this case, the experience is shown. In the case of Honduras, we can see where there are problems in particular and generate actions, control water quality in order to avoid or promote diarrhea, particularly in children. The other important element is to generate all prevention actions and prevention actions as well. I'm going to go deeper into this, but I'm going to point out something that we are supporting Honduras in this matter, and that is the preparation of a cost-effective analysis of interventions. And we're using 3 criteria. The first one has to do with the cost-effectiveness criteria, that is those actions or interventions in health that generate more health, because for every dollar invested. The second question is equity, and the third one is financial protection. These criteria were used to assess all health care, and we identify 70 ones, which are the highest cost-effective ones. The ones that were more cost-effective are those related, as Dr. Perez said, to the primary health care. I'm going to mention just one. Routine exams of high tension in risk groups, in managing groups of high tension, diabetes, managing diabetes type 2 patients, and those who are insulin dependent. So when this assessment was made following these 3 criteria, it was found that these were the most cost-effective interventions. And a little bit even further on, to characterize them on the basis of a group that at the end of the day, the government must produce the financing and the conditions. So one step further is to be able to provide resources, and thanks to the assistance of the bank, we were able to look at the fiscal impact and make a plan for a gradual intervention and implementation for over 5 years, approximately. The purpose was to be sure that the population could have access to that group of healthcare, and that's why when we think about lessons learned, we can define the group of services portfolio which focus on the population and the territory of these healthcare teams. We can, up to a certain extent, clearly define the interventions that must be provided and that must be ensured to the population for which they are responsible. But again, I insist it has to be a healthcare approach. The hospital is only participating at a certain point in the life of people, and therefore the responsibility for the patient lies not with the hospital but with the primary health care. The hospital will participate just a certain point in the life of patients, and that's why the approach of the responsibility of health care of a patient falls in these teams at primary healthcare. I think this is one of the most important lessons learned, and it's important to think about them and discuss them. Thank you. Muchas gracias.
The World Bank actually also does a lot of work in strengthening health systems. Could you share a little bit with us about the bank's priorities of integrating entities into primary health care and how the bank might work with PAHO in terms of this initiative as well?
Bueno, muchas gracias y perdón.
Thank you. And I'm sorry, Dr. Hennis, because I was late. I'm absolutely responsible for it. Well, this is very interesting. Thank you for for asking me to be here. We've been collaborating with PAHO and the World Bank for over a year. Dr. Hennis and Silvana are here following different initiatives. Our manager for the region said, and this applies also to the ADB, we said that we are following those priorities from our countries. That is, we are trying to focus on certain agendas from our institutions. Now, in the countries where we are working in non-communicable diseases, this is because we have a request, a very strong request from governments. And that's why there are multiple experiences, but I wanted to focus my participation in two large areas. The first one is with tools that we can deliver the governments, that is at macro level. And the other thing is from the patient's standpoint. There are crucial issues at patient level that I think we're not reinforcing as much. Innovation is most necessary there. So the first thing is the tools for governments. It's already been mentioned here. One of the innovations we can think of involves the rotation fund, and this is, or the revolving fund, and we all know this because of vaccines. This is what we are more familiar with. Those of us working with the government know how important it is. And something that we've discussed at World Bank is that it's a tool that could be used much more for non-communicable diseases, that is, technologies that may be bought at large scale, large quantities, and that is and their demand is quite foreseeable, so you can plan there. So this most certainly would be beneficial for the budgets of the countries, and we, as we said, we can give ideas to the governments, and the people who are here representing the governments could be an innovative tool that we can explore further. We, as a bank, and I think the ADB is the same, we don't have a tool of going directly to the revolving fund. It's always through countries, and it's countries that must make those decisions. But it's something to be analyzed. I think it requires an analytical work to understand the implications of this very well, and to have scenarios and alternatives of these cost-effective technologies that have been mentioned here. I think this is something that we can look at closely with countries. And I would like now to move to the second part, the question of patients. Here, for instance, in Costa Rica, we had a large project led by a colleague who is now working in Africa, and it was related to integration. Right from primary health care, we could follow up patients from CEPAIs. Most certainly you know about them is primary health care centers in Costa Rica, all along the network. And that was a wonderful experience. The project is about to be concluded, but the advantage is that we can identify the patient and we can connect it to the network. An innovation here that may be done, and most certainly has been done with cancer patients, and it's navigating, browsing patients from primary health care. In the case of cancer, this is quite a good example, because there are so many things that involve a patient with cancer that things get lost. Even with, we've had experiences like this in our own families. We can see so many different professionals, surgeons, chemotherapy experts, rehab, nutrition. There's so many steps to be taken that you get lost. And so to have navigators or browsers from the system itself and from primary healthcare that can help you to navigate all along this network facilitates and improves all results. This is something that we could explore as an innovation in terms of how to manage non-transmissible, not communicable diseases. I'm talking about Costa Rica, but there are other countries that also have this, to be able to identify a patient individually and following them up in the system, and then couple it with navigators, or they give it different names to it, but this is very interesting. Now, as regards patients, people, in the region in general, there is a concept that is being discussed more and more, particularly after the pandemic, and this involves the trust that people award to the healthcare system. There is a crisis, there's a trust crisis in the institution in our region and beyond our region, and this affects the health care system. There are cases where people don't trust or don't believe in what's happening in healthcare centers, starting with primary healthcare, because the problems aren't solved, because it takes a long time to solve the problems. And so many times this triggers the option of going somewhere else, to the private sector, for instance, where they have to pay, and that increases their out-of-pocket expenses. And this is due to the trust given to the system. So I can give you another example from something else, with vaccination. Laura Di Giorgio made a study in the Caribbean regarding trust in the COVID vaccine. This is most important because the degree of mistrust in the Caribbean was very high.
This analysis was very interesting and had good conclusion, and it's applicable to the system in many other cases, even though it was focused on vaccines. And this issue of how the system works to generate trust for the patients is key. There are often patients who are non-diagnosed, those who are diagnosed, how many of those receive treatment, and it's a down waterfall, and it's a cascade, and it's important to know whether they're using the system. And part of the problem, which is very unexplored, is all this related to the trust in the system. That's another ingredient that needs to be considered. And the last thing, measurement from the patient's perspective. In non-transmissible diseases, this is often more, it's developed. We hear the the outputs of the system from the patient, of the users of the system. And this is something that we could also explore in greater detail, give this alternative to the governments, to management and decision makers to involve the patients, and that will help us to generate a greater trust in the system, to feel a part of it, that there's a connection and a greater empowerment with regards to the healthcare system. There are tools, but we need to begin to use them and give them a greater impulse. And so I want to complement this idea moving forward, because it also brings it to the table and generates dialogue. Thank you very much.
I think we have reached our time, so we won't have time for further discussion now, but really thank you very much for being a very participative audience and for sharing perspectives on the project in Honduras, as well as perspectives from the bank on the importance of NCDs as well, and the importance of primary health care. And as we roll out the initiative and better care for NCDs, which is quality improvement, we look forward to deeper communication and collaboration with you, as well as with colleagues from member states, to reduce the burden of non-communicable diseases and premature mortality in the region. Thank you so much.
Buenos días.
Good morning, everyone. I'm Ali Gedi. I'm the Director for Communicable Diseases in Washington. And as my colleagues were saying about non-communicable diseases, I need to wave the flag for those and for the countries of eliminating communicable diseases in primary health care. I have the privilege today of sharing with you this presentation with two colleagues, Dr. José Antonio Montiel, who in a few minutes will join us. He's the director of the Paraguay National Center, and talking about elimination of malaria. And also have Leandra Abarca, who's the leader and director for the program in elimination of TB in Costa Rica. Just a few words to begin this session. I believe that I don't need to convince you that the eradication of transmissible diseases is based on an absolute perfect integration of primary health care. The challenges may be enormous, but that is the route that we need to follow. I don't need to convince you that innovation is the secret as it is for non-communicable diseases. This is also the secret to eliminate transmissible communicable diseases. We're talking about improvement in diagnosis, surveillance, and drugs and treatments. Please join us. I am going to use perhaps a slightly different format, and as I'm the moderator, that's my privilege. I'm going to begin with a short presentation. There's too many slides, but I'll go over them very quickly, and then I will give the floor to Dr. Abarca, who will also share her experience with TB control, and then Dr. Montiel. And I am going to also give myself the right to perhaps ask for more detail in certain things about their presentation, of their experience in their countries, and if we have time, also open the debate for the forum. I hope that the colleagues from IT can put the presentation up, which is already set up. Thank you very much. We're talking about an initiative which began before the pandemic. We now need to relaunch this initiative with all the negative impact that the pandemic, with the eradication. We have a long story. We have a long-standing history of elimination milestones. Malaria is one of them, but we still have maternal transmission of HIV and syphilis, and control of rabies, and we have example of several countries, but we are in a context which has an impact of the pandemic, and we're still leaving that, especially in primary healthcare. This is a very long list. There are more than 30 diseases and conditions that need to be eliminated by 2030. There may be 31. Because there was also monkeypox, which wasn't before existing in the Americas before 2022. And also you can see that there are certain diseases that have a management which are very different, which are preventable and veterinary public health and certain conditions, and tropical diseases which and sexually transmitted diseases as well. This is the basis of the integrated services in primary healthcare, and I want to highlight the 3 I's: investment, innovation, and implementation. I think this is vocabulary that you are all specialists in healthcare systems and services. You've been employing this vocabulary for some times, and you understand this implementation of this initiative for eliminations. I want to highlight a few groups of diseases. So maternal fetal transmission of EMTC+, this is HIV, syphilis, hepatitis B, Chagas, and Zika, HTLV. And we want to mention the implementation and adoption and scale up of rapid testing, dual tests. We have a long-standing path in the Caribbean. These countries have been the champions so far for the elimination of vertical transmission of HIV and syphilis. And we hope that in the next few months, years, have a greater impact in other countries of the continent. We also have very well-known strategies for tropical diseases, including in deworming and vaccination campaigns. And there are certain countries which have difficulties for accessing with certain access difficulties, so they have campaigns twice a year, and that has had very good results. We're also talking about the elimination of cancer, such as cervical cancer. We have a vaccine available for HPV. There are services for screening with good swab tests, and we know it can be detected and eliminated in a short or long term. And we also have the availability of the vaccine. Viral hepatitis, of course, hepatitis B with the vaccine prevention, but also hepatitis C, and detection is 50 cents of $1 is the test cost, and the treatment has also come down to $79, where compared to the astronomical figures a few years back. And we also have a studied program which has been considered. I want to mention Guyana is a country which is a champion for the elimination of hepatitis C, with the greatest implementation of the program. Also, in regards to innovations, we're talking about service delivery models. telemedicine, digital health, and strengthening of laboratory platforms. We need, and we have good perspectives to strengthen laboratory platforms. And something which is always very detected by Dr. Barbosa is the regional and local manufacturing, production of laboratory tests and drugs, vaccines, and new technologies, really without doing political campaign. But one thing that can be said is we're in a perfect moment of the history of public health in the Americas to reduce these factors and allow us to other countries to move forward in terms of elimination. This is a very long menu, depending on each country and their context, geographically and human resources, and considering inequalities. But I want to again mention the support of the funds by the PAHO, and it allows us to have access to drugs and tests which are pre-qualified with good negotiated costs, and that has been important at this time. Dr. Barbosa yesterday mentioned HPV is currently $2.90 in the last few weeks due to this fund. And the cost for hepatitis C has gone down to 72 cents of a dollar. And this is also optimistic. These are the milestones in the elimination of communicable diseases in the Americas for the next few years. It's been decided on an international level. And it can also be considered as micro-eliminations. We have the goal for micro-elimination in certain sectors of the population or in certain geographic regions, and that way we can reduce the load of communicable diseases in our regions. I hope that wasn't too long, but it's my job. So why would we talk about TB and malaria? All of you have had to manage at some point in your degrees, whatever your background. And so they're the old enemies that are currently still killing people, but we have good experiences. Paraguay has been one of the champions to eliminate malaria, as has been Argentina and Belize and El Salvador, and we have several countries who are following the same steps with clear goals and specific deadlines. 2025, for example. Tuberculosis, the same comment. The goals are to reduce incidence, reduce mortality, and we are interested in hearing the experience of Costa Rica, who have had very good results. Dr. Leandra, please. Good morning, everyone. My name is Leandra Barca. I'm a doctor epidemiologist from the Social Security System of Costa Rica. I am very grateful for the invitation of sharing with you the experience of Costa Rica with regards to the integration of surveillance and management of TB in primary health care, because as you will see over this short presentation, it is a win-win situation. Primary healthcare wins and also TB management.
Let's start. And I don't want to bore you because there are many things that I can tell you in relation to the experience in Costa Rica. However, we're going to mention 4 items. Very briefly, I'm going to go into the generalities and context of our country and how TB behaves in Costa Rica. We're going to be talking about these key issues which have been previously mentioned, either today and were mentioned yesterday in the various sessions, how we've been able to integrate different activities in controlling and approaching disease in primary health care and its impact, the challenges and conclusions, and lastly, a success case which we think is important to look at. Costa Rica is a small country. We're about 5 million inhabitants at present. As it happens with most of our countries, we have very clear health care, which is led by the Ministry of Public Health in Costa Rica. The ministry works with many healthcare institutions which deal, according to their competences, different healthcare determinants having an impact on the control and presentation of this type of diseases. The Costa Rica Insurance Fund is one of them, although there is a large offer of private health care offer, and as you could know, the impact that Social Security has become more and more important. And so through the different services and healthcare centers, work in a network and try to get to everywhere, independent of the place where we are, the country we are, and how far away you are from a hospital center. This Costa Rican fund works as a comprehensive healthcare network with 3 national hospitals, 6 specialized hospitals, 8 regional hospitals, 12 peripheral hospitals. But then we have the other 3 elements involved, and that's where we truly execute and implement primary health care. We have 105 healthcare areas in all the territory. We have 108 teams with various professionals and healthcare professionals, and over 500 periodical visit centers, ensuring that independent of the place in the country where you are, you can always have a healthcare center next to the community to identify the determinants that may be affecting the various events or diseases. Hence, when you think of TB, for instance, you have to envisage 4 basic institutions: the Ministry of Health, the Social Security Fund, which we're going to see very briefly, which is in charge of controlling and approaching and following up patients independent of where they have been diagnosed, either in the fund or in the private healthcare system. Then INCIENSA, which is our reference lab, and the Ministry of Justice and Peace. In the penitentiary centers, we have a vulnerable population. We have important cases in Costa Rica in these places. So these 4 heads or focal points to deal with TB through its various subdivisions, for instance, hospital, healthcare areas, CAIS, EVAIS, public and private labs, penitentiary centers. They are involved in detecting and preventing and making the diagnosis and approaching and doing the follow-up of TB cases for all the population, independent of the age group and the social and demographic situations they live in. We all know that TB is a serious infection. By 2022, it was considered the 2nd death cause at world level, except COVID, as Pajo said. Costa Rica is one of the countries of low incidence because we've been able to have a rate that is lower than 10 every 100,000 inhabitants. But to have this incidence rates and continue forming part of the countries with low incidence rates, we must articulate this as we saw it with all the sessions yesterday and as mentioned before, between the public policy, the interinstitutional and intersectoral coordination network, healthcare networks, joining all the different communities and giving access in the same conditions independent of where they are, and also strengthening primary health care activities. Very briefly now, what's Costa Rica like in relation to the epidemiological behavior of TB? As we can see in the orange line, our incidence, and the blue line is our mortality rate along the years. The trend has been downwards. We have also pointed out the times where the various strategies a long time PAHO has established at world level for TB and the end of TB, the time they were implemented, and when the healthcare processes, we can see a reduction of cases. And so we can see the effectiveness and the positive impact of these cases, except for the pandemic years, which are the past 2 years, 2021, 2020, 2021, 2022, which I haven't mentioned there. As regards the real and expected incidence, the blue line shows the real incidence from 2015 to 2022, and the expected incidence as established by PAHO, keeping in 2022 a gap of 123 cases approximately. Now, in relation to behavior by age and sex, we know that TB is not predisposed to a certain age group or a group according to the sex. However, the behavior in Costa Rica definitely, as we can see, is in the masculine sex, in adults and young adults and the elderly. How is it that the country has worked on integrating the various activities in the approach of TB and surveillance of TB in primary health care? I have focused on 3 items which have been mentioned all along this session. The first one is the legal basis, the rationale. We have to have documents allowing us to have a legal and juridical backup for the various primary health care at community and local levels to comply with the various control and prevention activities. We have different laws there, the general health law, the decree establishing under the law that the surveillance protocol and approach of TB is a law, and therefore it is compulsory, and it allows for account rendering regarding compliance. And there are also different standards that the various institutions must update and strengthen. The second point definitely involves the intersectoral network. It's always going to be led by the Ministry of Healthcare. However, it's going to provide the various institutions and the various basic teams to carry out each one of the activities of the program. Last but not least, human resources. I mentioned this yesterday. We have to invest in human resources. It isn't easy and it isn't cheap. But we must show evidence through data that there is a positive impact. In this advice or in these basic healthcare centers and periodical visits, we have staff with lots of expertise, well-trained and innovative teams with dealing with all the challenges after the pandemic, and that has also had an impact on TB. Through the integration of the various elements of the prevention, detection, diagnosis, support, and follow-up program in primary health care, we've been able to strengthen and sustain all along the time the various indicators and to be able to take actions for improvement, particularly at times of post-pandemic where there has been an important drawback. This healthcare system has allowed the TB program that due to its characteristics, accessibility, integral coordination, permanence, and follow-up, as well as continuity, we can have inputs and tools in order to work from the local level and with patients specifically. There is a lot to be said about the experiences in each one of the items of the TB program. However, I have posted some summaries, for instance, prevention of TB, Primary healthcare has made us able to aware and communicate and control the disease that is latent. It has allowed us to make detections, to make active and passive searches, to make an adequate follow-up and study not only of cases but also of contacts, and to train human resources that I mentioned. This is most important in this process. As regards diagnosis, something that has been innovative and has allowed us to make a lot of progress in primary health care. That is, all healthcare areas with their device or the corresponding device to have access to quick molecular uh, tests. And it's been shown that if we have them in the healthcare areas, we don't have to transfer any samples, and this involves risk. So in that case, we could improve diagnosis much more quickly. And then lastly, there are lots of experience in relation to treatment and follow-up of cases and the various contacts. For instance, support in the strictly supervised treatment, support to improve compliance. And at the end, I'm going to show you a success case. Pharmaceutical care, all patients in their community, the chemist, the pharmacist would sit down and explain the effects that the person will have, because although the period to take those drugs is long, it should be kept up. That is a social approach from their community with health determinants, an interinstitutional coordination in case the comprehensive healthcare team sees the evidence that a follow-up must be made. And as it was said yesterday, the introduction of telemedicine in healthcare areas that are included in this advice, because we didn't transfer a patient to the coast or to the area where a pneumologist is located. We can do that through telemedicine, which is already in the primary health care. And in a very schematic manner, I can show you some photographs on the top left-hand side. We can see the sample of a sputum taken. In Costa Rica, we have indigenous populations with a dialogue, and each one of the survivors knows how to explain and raise awareness of how important the various components of the program are. On the top right-hand side, you can see a photograph, which is our success story. Is following a treatment under supervision. On the bottom left-hand side, we have nursing care. They do it at the center, but then they continue at home. And then we have a pharmaceutical care. Of course, active searches in communities. Sometimes they are more urban communities, and sometimes they are very rural. At the end of the day, then, the integration of all these activities regarding TB for approach and surveillance in primary health care gives us a lot of guidance about how to execute the activities related to prevention, diagnosis, treatment, and the service of these events. We are fully focused on users and their environment. When I see these conclusions, I can't but recall the basic scheme of the health determinants that we all know. Through primary health care, we are able to reduce inequalities in the approach of this event and many others, and to increase the effectiveness of healthcare actions. And something that I would like to mention now is how important to give evidence to these actions.
Of course, this is difficult to strengthen the norms and the laws, strengthen human resources, maintain the team and the management, and intersectorial. But we need to show the evidence of the positive impact that these programs are having. So this is a win-win. That's what I said. The program wins, but also the primary healthcare, because it shows through numbers and impact and the experience how important this has been and its role in the control of diseases. They're just coming to an end. This is our success case. I chose this patient who you can see he's smiling and looks he's like in a good general state. A time back, months back, this patient was living in the streets. He was detected in an active screening program with a community primary health care agent by the church on the outside the church, and he was encouraged to give us the sputum sample, and then we did a bacilloscopy because we didn't have available molecular testing, and it was positive for TB. So this patient who was living on the streets with TB, and the way for them to get the diagnosis was accepted. So the first level of primary healthcare began to sensitize, educate, and generate the insight of what was happening with this patient and how it would affect those people around him. And so it generated some coordinations, intersectorial, institutional, with the support from different community leaders, so someone to help them get a place in a homeless shelter, get a job so that they'd be able to look after cars and have some sort of income, and a complex program allowed us to begin the treatment and be in also many months after this patient, we tried to see if anyone else had taken a first photo when he began the treatment, but no one did. And this photo was his last day in the treatment, strictly supervised treatment. Currently, he's cured from TB, thank you to the primary care system, which allowed the program, the TB program, to represent and guide this. And definitively, this is a person who will continue to promote healthcare and in his community the importance of healthcare. So that was presentation. Thank you very much for everything. Thank you, Dr. Abarca. We will have time for question after Dr. Montiel's presentation. Dr. Montiel is the General Director for SONEPA, the Ministry of Health of Paraguay. It's a pleasure to have you with us in this session. Once again, malaria is one of the important flags under which we are working on elimination, and Paraguay is part of the first cohort to eliminate malaria, as well as Argentina, Belize, and El Salvador. It's very important that we have good perspectives and prospects. Expectations. Sometimes the French gets mixed. We have high expectations for the elimination of malaria. We have the Amazonic area, and there's Mesoamerica. And one country at a time, we need champions who are going to teach us and the lessons learned, and Paraguay is one of the best examples. Thank you, Dr. Montiel. The floor is yours. Good morning, everyone. It's a great satisfaction for me to be with you here today. I want to share a little bit about the experience of integration of the program for malaria and the primary health care and its elimination and prevention and reintroduction of malaria in Paraguay. I would like to share a little bit about this process, which began back in 2005. And 12, and over the years I'll explain what we've been doing over time from the Ministry of Health, and the plan for the elimination of malaria was beginning to be designed back in 2005 to 2009, and it included the participation of other actors and participant and partners as well. It was the different healthcare services, the ministries of health, the regions of healthcare that we have, and a communications department, and then also from local government and the Ministry of Education and Culture. Before 2005, the National Ministry of Health had a national program against malaria, and it was organized by the Ministry of Health. And so now it wanted to establish certain allegiances and alliances between other partners as well. So in 2011 we published the National Plan for the Elimination of Malaria, and then 2015 there was a new national strategic plan to prevent the reintroduction of malaria in Paraguay between 2015 and 2019. In this first stage, 2015-16, the activities for diagnosis, treatment and response were the exclusive responsibility of the resources of the Ministry of Health. And then in a second stage, 2016 onwards, the activities of surveillance were incorporated into other dependencies which are dependent on the Ministry of Health. And for those physicians who are involved in laboratories and different departments where there was a possibility to detect malaria. From 2017 onwards, we began to have financial resources from the World Fund to increase the effort and accelerate the efforts in certification and implementation of a strategic national plan. And this was a little bit of this timeline, was the implementation of this national strategy, and it was incorporated with the informatics system of the Ministry of Health. And then finally, the story in 2018, the World Health Organization certifies that Paraguay has eliminated the autochthonous transmission of malaria within national borders. So the components of this strategy and its participation for the response to malaria, it had a passive detection, diagnosis and treatment in the healthcare services, and then this was also done continuously through the border control and controlling imported cases. Then we had a ontological surveillance and control of vectors. It takes a lot of the effort is focused against dengue fever, and we're now under a new epidemic of dengue. We always want to identify the vectors. This is the important surveillance, the job that is done by the biologists who work in our Ministry of Health. Promotion of health through the National Program for Health Promotion, and then communication was also very important. The governance model for malaria in the 18 sanitary regions of the country brought together the response of all the different levels of primary health care, and each region, which are the departments or states in other countries, each region has its governments, and they would implement their model of management. Some more have a greater dispersion of population, some are smaller, and there's a greater accessibility to the healthcare services. And within those differences that you can see there, we have developed strategically each model. And regarding this integration process, it is continuously maintained through the strengthening of surveillance capacity, and it has this diagnosis, treatment, investigation and response strategy. and this is integrated in the healthcare services. Also, leadership and the experiences of the national program for the elimination of malaria is incorporated, integrated with the other components as well. This is basically what I wanted to share with you. I also want to say that the continuous support of the PAHO. We're always working and trying to do this follow-up, especially when you have new personnel and doctors who have just finished their training and they want to learn the expertise to always consider malaria. We work closely in this area with the border control, especially Ciudad del Este, which is a triple border with Argentina and Brazil, and also other places where we have dry borders as well. Thank you very much. Thank you very much. We're now going to have a dialogue or conversation style. I have a question for our two colleagues. How did you manage, Dr. Leandra, you mentioned the rapid molecular testing. How did you manage to establish in your program new technologies, rapid tests? Perhaps begin with Dr. Montiel. I'll pass you the mic, of course. What has been the impact of the integration of new in your programs, if you want to bring any other comments on this? We, with integration, we've managed to adapt to the needs that we've been finding in the different healthcare services. Before this integration, we would talk that the Ministry of Health had an agreement with the leaders of the different population groups. We do the training to do the testing, and so with the new with this integration, to have the family health programs, which has strengthened primary health care. Thanks to this, the hospitals and the district hospitals and regional hospitals, they've began to have a greater developed laboratory and teams. And so the government this way has invested more to try and have new detection methods which give us a precision diagnosis depending on the complexities of the healthcare system. A personal comment, I think that in many countries, even when you're trying to maintain the elimination, you need to combine microbiology laboratory with molecular testing is the way to go. Dr. Leandra, you mentioned and highlighted integration of rapid testing. Could you go into a bit more detail with this? Yes. As I mentioned,
there must be a strong wish and political support of the various heads of institutions. In Costa Rica, we have a national TB commission. It's formed by a focal point of at least the four main institutions in charge of providing scientific evidence. And there, PAHO has been a strong ally, establishing the main recommendations. The National Vaccination Commission is in charge of giving the rationale of the impact of implementing this new diagnosis test. Thus, the commission and take it down to the various positions in the institutions and persuade their managers or health authorities about how important it is. It isn't easy. It hasn't been easy. COVID has taught us many lessons, and in the case of TB, we've been given the chance of opening doors regarding rapid molecular tests. There has been an introduction of new tests for emergencies, and so the possibility is open for this in some hospital centers. And then, after having the experience of these hospital centers, we have documented how important it is to look for the administrative and economic component and take it down to the healthcare areas. By 2024, all healthcare centers will have quick molecular tests. Thank you, Dr. Leandra. Once again, I'm going to ask a question for both of you. And then Dr. Gonzalez will help us with a battery of questions from the floor. Whether it's for malaria or TB, we've got a load that is heavier in indigenous populations. Perhaps you could give us some examples about how to deal with this in the elimination phase and in the reduction of the load with indigenous populations. Perhaps Dr. Montiel could start. Well, truly speaking, Paraguay has this characteristic. In fact, there are many areas in our country, particularly in Chaco, where there is a predominance of indigenous populations. We always work following the intercultural perspective. The Ministry of Health is focused on the health of indigenous populations, working with indigenous leaders. There is a National Commission of Indigenous Leaders gathering in Asabi. It's through them that we've been able to hire indigenous promoters. An indigenous promoter works for the Ministry of Health, receiving instructions permanently and trained to work following the guidelines of the Ministry of Health, of course, and through the Family Health Unit. We also hold meetings with them. I think that this has marked that openness by the indigenous community to be able to get to them in the work we do with malaria. In relation to TB, things haven't been easy. This is due to the characteristics of this vulnerable group. Likewise, however, as it happened in any other places that have been defined and identified, there is a primary health care expert, and that's their point of entrance. This is adapted to the characteristics of this specific population. It's still a challenge to make a follow-up, although there is a possibility of having various communications among the advice that these populations use to go from one place to the other in order not to waste treatment. But the key issue is the expert in primary health care. That's our link with the population. It allows us to know and raise awareness about this importance. Thank you. I think we have questions from Honduras. We have something like 10 minutes, less than 10 minutes. We have question for a couple of questions. We have time for a couple of questions or comments, not necessarily questions. First of all, I'd like to congratulate both of you on the wonderful experience that you are sharing with us. I think that as countries in the region, we share many activities so that programs can reach the community. In the case of Honduras, in TB, through the health regions, we've trained community volunteers They make a search in their own colony, in their own place where they live, because there are areas which have some difficulties in terms of violence. So the people who live there, while they are trained, we have also introduced molecular tests. This has been quite a difficult process to get the chip out of our health provider. That is not bacilloscopy, but it's through molecular tests that we can make a quick diagnosis of the bacille, but also bacillus, but also resistance. We started in 2015, experiment risk, and then we have moved on. We went to empty reef to ultra tests. We have two teams working on ultra. And this year we introduce 3 teams of 10 colors. It's not only that we have a quick diagnosis of resistance, but also a quick diagnosis of resistance to other molecules. Now, what's happened here? We've been able to reduce drastically the diagnosis time frame, because we would start with a treatment thinking there was a sensitive TB, would start with that, and as checkups were doing at the second, fifth, and sixth months, we could see that there was some positiveness. We made culture, and that would take 5, 6. So having incorporated midget XDR as a diagnosis method, we've reduced that for 14 days. So we don't give a treatment of 6 months for sensitive TB, and we are doing it according to the resistance. We want to move forward. What we've requested was to introduce TrueNet. This will give us, in a short period, the resistance of second-line drugs. That favors us. Through the fund, we've been able to see how we favor people who live on the land, but it's considered an island because you can't get there if it's not by air. So payments are paid, any transfers they make to the coast where they can start treatment. And so we are in that process, doctor, where we are starting treatments at national level of a second line. The first line is everywhere, but the second line, we are very careful that there is no abuse of drugs and create a resistance. So it's effective to involve the community, to be able to make diagnosis, to make a search, deliver the drugs, and we've tried to approach the communities by short announcements, just 30 seconds left. In California, in INGLES, in Tulupan, and also in sign language and in Spanish. So in that way, local people can broadcast it in their local radios, and it's part of the social commitments that companies have. So we are conveying information about TB in their own language. In that way, people get closer to the COVID, to the centers. COVID was a disaster. There were about 1,000 cases that we were unable to detect, and we don't know among the deaths whether they had COVID and TB. We did have 48 cases of TB that we could diagnose and follow up. 2 died, but we don't know about the rest of them because no autopsies were made, so we don't know what the mortality was like during that period. We are increasing, but molecular tests are really successful. Thank you. Thank you, doctor. We have Cecilia. Apart from adding the component of indigenous health in a very particular territory. Thank you. I'm Cecilia Cunha from PAHO and WHO. I think this panel has been most interesting, as well as the previous panel in non-communicable diseases. It shows that, in true fact, from the standpoint of patients, There are no borders that we set up to chronic diseases or non-communicable and communicable diseases. And so my question involves that comorbidity or multimorbidity, how you, in your own countries, approach at community level from the perspective of primary health care patients that have chronic diseases such as diabetes, but also suffer from TB. And that's my question. Thank you. Thank you. I think this is an excellent question. In Costa Rica, we do this in a comprehensive manner. We make no difference. In fact, one of the main sources of vulnerable population is our chronic consultations. And there we also have to change the perception of the healthcare provider because they think that they have to go out and look for patients that are TB suspicious in places that are not in their daily lives. So one of the places implemented at hospitals is that in any queue where patients would come up for their diabetes or hypertension drugs, twice a week, depending on how feasible it is for the healthcare center, they have to ask and make an active search of TB in the same way when they're making nebulizations, but because they are chronic obstructive pulmonary patients, it's important that this is not unlinked. On the contrary, they are coexisting, and we can all benefit if we detect it. Because when a diabetic, we know that they have TB or phlegm cough. Well, if we can identify that, that's going to be beneficial for the healthcare service. There are 3 further questions that would take us time from my lunch, but we are at your disposal. Thank you. I'm from Peru. We've got all these problems, particularly in the territory where I come from, and one of them is malaria. And my question is, how do you do it? How do you go about it? And then your experience that you already have in place and we don't. And we have outbreaks in originary populations. So I'd like to see what specifically, how do we land this with community agents to see whether they can help us out in the treatments, and also the question of fumigation, the use of insecticides, and the weather, because the weather is changing, and how are you dealing with that? Now, the other issue regarding TB, well, poverty has an incidence in these territories, and it's becoming worse and worse. I wonder whether you have any work so that in this place where we can make decisions, we can invest and make promotional preventive actions at primary health care level. I wonder whether you've made any studies of cost effectiveness looking at molecular tests. Thus, we could see in these countries if it's productive and timely and beneficial cost, particularly for people who are far away and don't have access, to start working with the experience of molecular tests for TB. And I would like.
Thank you, Dr. Montiel. Regarding vector control, that is the Ministry of Health department, which I currently work in, and we work with the notification of suspected cases of arboviruses, and through that we block the physical elimination of the vector and also fumigations to do a chemical blockage. It also involves the population of mosquitoes, because we have a lot of, especially in the urban areas, we have Aedes aegypti, the vector for malaria, and perhaps that isn't so many as in population of LA. And so that is also an element which is our role. Thank you. And we'll have 3 more questions before getting the answers. Thank you, Jonas. Cristóbal Cuadrado from Bolivia. I want to ask Ansel as well. The challenge of integration, which is the umbrella for this session, which is the symptomatic that we have 2 panels, panel A, panel B. I would want to ask this question. What specific or concrete challenges do you see in your countries for capacity building for primary health care, for there to be an integration of the national programs for control of communicable diseases and elimination of communicable diseases? What capacity building of human resources, technologies in the first level primary care, because there we need to perhaps consider what are those challenges specifically in your context, and what experiences could you share following that line. Before colleagues answer, there are 2 flags, but there are many challenges in this. We've the challenges we've said is the eliminate cervical cancer, because here we're combining different platforms. I'm from Uruguay. I'm the director of the Department's Health Services. I want to congratulate the panel for everything that you've shared and what your countries have improved, especially Dr. Abarga for your presentation in a country which is a first level in healthcare in America. Just congratulations for to your country. What I'd like to share, considering this vision and trying to bring something to the table, is that I believe that the primary health care that we have seen from the different perspectives is based mainly on something that we're doing well in Uruguay, and that's why I'd like to share it for the group. The main thing that we have is a administrative pyramid which directs and guides the strategies and the programs in primary health care. So in our country they come from the Ministry of Health through the Ministry of Health and 2 departments which are called DIGECOM and DIGESA, which are 2 departments which design programs to us, who are the directors of healthcare departments. And they will direct the strategies which have been considered from the top of the pyramid. Those strategies, to apply them, there is a great importance is these department directors, because we're the ones who coordinate and determine what needs to be done to apply these things in primary healthcare, and that is often the human resources. And those resources, we need to manage them. And so the Ministry of Health, what we try to do is determine that we can coordinate the human resources from the community, whether it's the municipalities or from the public healthcare system or the private system, and we can coordinate the program, that primary healthcare, and it's brought down to the ground level, and we can determine. We're a small country, Costa Rica also, we're quite similar to that, but there are some countries which are enormous, so human resources, the further away they are from the greater urban areas, it is more difficult to obtain them. And so those human resources, if we don't have them and we don't coordinate them, it's impossible to coordinate a primary healthcare network. That's what I'd like to share from our experience. I think the most important thing is that all these strategies are important, but it is very important to have a correct management, and in this country it is done through the Ministry of Health. Thank you. Astorga from the International Development Bank, and adding to this about the 2 panels about chronic diseases and communicable, a thing that I'd never really considered before is that epidemiological surveillance is generally considered for communicable diseases, but chronic diseases are managed with every 5 years with surveys. But the drama and mortality comes through the chronic diseases, and developing new policies every 5 years is maybe not that's crazy. So perhaps it's our responsibility for technicians, and we need to consider if it's each on this surveillance of the epidemiological diseases. We need to consider both things, communicable and chronic diseases. We often think that chronic diseases are not a public health issue. So first we need to reflect on this. What does the PAHU and WHO think about this? And what are the steps to follow? Because I think it's absurd. You show us the improvement of chronic diseases and in 10 years. I don't think it's absurd. We know we need to determine that there is in fact 6 years. We can't wait for 5-year results. And so I think from innovation we are aware, but that is what I think on an organizational level we need to bear in mind. With regard to what was explained by the colleague from Bolivia in Costa Rica, the challenges, we have many, and in all countries. But from my training as an epidemiologist, I would say that the main challenge is perhaps improving and strengthening decision making based on evidence. There's so much which is done on a local level, and the doctor mentioned this earlier. What do we do with a diabetes patient or hypertensive patient who also has TB? There is evidence and experiences that have been shared, and there's documents that allow you to make decisions based on the evidence, and that is going to allow the program to be sustainable and strengthen primary health care. Issue which we're currently managing in Costa Rica after the pandemic, we saw the TB cases, they began to be seen in a much later stage in the hospitalary level. And we saw that many patients were detected with complications because they were detected at the hospital, or they died during 2020, 21, 22. And the impact that this has for the fact that we weren't able to detect this patient in primary healthcare level in all the different contexts, the potentially years of life which are lost and all these other things, because we need to justify the incorporation of new innovations and resources and human resources, etc. So in Costa Rica, even though there are many challenges, I think is that we need to consider to collect all the data that we have, document it so it can be analyzed and can justify and strengthen everything that we're interested in focusing on. Thank you. Thank you. I'd like to once again thank Dr. Montiel, Dr. Abarca for their presentations and congratulate everyone who is in these sessions for your questions and comments. And I'm going to end with my innocent. There is no elimination of diseases in the America regions without the strengthening of primary healthcare system. Thank you very much.
Okay. Bueno,
Good afternoon, everyone, those of us who are here in this session of Panel C, which is planning and organization of interprofessional teams for social participation. My name is Ariel Solar. I'm a Health Promotion and Social Department on Health Unit Chief of the PAHO, and I'm going to coordinate this session. I'm going to do the keynote on this session, and I'm also going to be the moderator. We are fortunate to have in this session, and the keynote I'm going to introduce, we have 4 experiences of different realities that work in different contexts that we think are essential in this discussion. There are a few of us, so perhaps maybe we can have a bit more of a dialogue, try to listen to the experiences. Firstly, as we said, the issue that we want to talk about are certain reflection or ideas that are going to be seen in on the territories and to address social determinants in primary healthcare. And as we said, the focus is going to be on how are we going to put into practice primary healthcare with intersectorial determinants and social determinants of healthcare, and how do we get social involvement with a focus on and the management of inequalities. And there's an ethical command to be able to monitor the results, and this is essential in this fund. It may be a limitation in the advancement of certain program, especially in our region, which is very disequal. Here are the main issues we're going to talk about: intersectoriality. Secondly, we're going to talk about primary healthcare, social determinants, and social participation. And this order isn't on priority, but how we're going to do the discussion through this. So firstly, I want to talk about territory. In the previous session, we mentioned that we talked about the territory, and it's important that intersectorial work needs to be done in the territory, understanding that it extends further than geographical limits of an area or a limited area which is depends on the administrative divisions, and it's related to historical processes, especially related to indigenous communities, originary people, and their limits and their relationships. And so the territory also implies visualization of the context and the scenery where everyday life takes place, and therefore it's where health occurs. And so also in the territory, it is a indicator of well-being and illness of the society that is affected by social relationships, and it depends on the social participation and political involvement regarding decisions and opportunities and decisions regarding healthcare. So this division of territories is also important for a integral and comprehensive management. There are certain authors who've been talking about inequalities in this area because it is often something that we're concerned about regarding climate change, because there are certain territories which are more affected regarding climate change and the advancement in their areas. But it's also important because certain situations take place, such as where prisons are or where dumping grounds are. And so there are certain communities that feel misplaced or ignored. And so in the territory, there is also is where life takes place. So we need to consider that this concept of the territory is, and fieldwork is where key factors for health and illness occur. And in this sense, when we talk about the territory, it's important that we need to reorganize our public health efforts, focusing not only on programs for specific diseases, but for a comprehensive approach for social conditions and determinants that affect people's lives. Certain authors say that the first primary health care is in the family, and the first caretaking takes place in the home, and that is where health is built. And so in that sense, and considering this framework of how we understand territory, we come and talk about intersectorial work. And healthcare is more than just medical care, because more than a healthcare center. And so the processes that take place in the territory between the different actors and the countries who are involved and all the different people who are there are certain situations that impact their population's well-being. So in this sense, the intersectorial in the region has been many different concepts relating to health and the processes that depending on how we prioritize different processes. And intersectorial work depends on how we work together and teamwork and a global governance. An issue which is very important of these determinants is intersectorial work needs to be considered. And when we talk about intersectorial work, often it focuses on the need of not replicating actions and synergy. And it's a bit related to efficiency and also its technical side. And so when you consider this intersectorial work, we look at the necessity for, because of the complexity of the problems. In the previous session, we have problem with chronic diseases, obesity, mental health issues, and there are many ingredients which are involved in healthcare. And so the complexity of this management depends on the determinants involved and the many actors. And so the intersectorial work also mentions or refers to the need of treating inequalities. Inequalities are present in what occurs in the centers and services providers, but also regarding to social security, organization, and political action. So not all intersectorial work reduces inequalities in healthcare. But if this intersectorial work looks for transformation, it will help to reduce inequalities and redistribute power. This is also important for us to highlight because we'll hear about this further in our speakers' talks. Another issue to mention are the social determinants of healthcare. This is organized by definition by the World Health Organization, and also there's a graphic by the California County which says that when you want to build just and healthy societies, it won't occur if there's not a healthy community, a healthy environment, and a more just community. Because when there are inequalities, over time it builds up, and so you need to focus certain stages of life. And when we begin to talk about this issue in the territory with an intersectorial work plan and how to be present with the social determinants, that way we can come up with a strategy for healthcare. And we have been primary healthcare, we've been talking about this in the previous days. So this is also the emphasis that can be given. How do we focus on the primary healthcare, which is where the first care occurs. In this sense, the strategy for primary healthcare isn't only related to relieving these effects on healthcare, on health, and not only a secondary prevention, but it is also looking at promoting healthcare. How do we create spaces which health is going to be present? How do we improve quality of life and well-being? And these are key elements when you consider satisfaction of the population on the territory and the healthcare system. And so health and territory is going to be very involved. So finally, to consider and reinforce these ideas, when one talks about the social determinants of health, one has to consider, there is widely known, is what takes place further outside of the healthcare system and the institutions. It may be true, but it's not the only truth, because we are trying to work on how to consider social determinants of certain initiatives which are prioritary, such as the treating non-communicable diseases, elimination of certain diseases. And that is what we're working on currently. Is we are trying to look at clinical practice, and it's very important how we consider the territory and how the primary healthcare system considers it and the conditions that are ideal for generating health and promoting health, and is going to increase the community's health. And also the vision, the definition of health, how are they also going to consider those things that are not necessarily directly related to health care, but it's very involved. And here we can see the relationship between primary healthcare in everyday practice. There are also determinants which favor intersectorial work. And when we think there's a program that isn't ineffective and in a very unequal and doesn't consider the social determinants of a community, this implies that there are barriers not only in offering the services, but also in the demand. Those social determinants that generate a need isn't generating a demand or a service.
Even beyond the financial capacity. So we think there is a role of social determinants that help this program and that also show the requirements of other sectors. Many of the territories have those installed capacities coming from PHCs, so a social prescription approach or a community intervention or something that you advise, such as physical activity. If you haven't got the context of the offer in the territory, then it boils down to nothing. And therefore, we think it's fundamental to think about the programs. We think about programs not about the causes that produce inequalities, but we think about health problems and the natural history of health and disease, but we don't include the causes and what helps you improve health are not the same causes of specific problems. And so I go back to my initial statement. We not only want to focalize on specific activities, but we need the specific activities. Of course, social determination helps a better effectiveness of the program. There is a fundamental role to build healthier communities and societies. And so here we have intersectorality, participation, social determinants. And what we're going to see here is to translate this into experiences that can throw light on this topic. And we have 4 experiences. One, it's a focus on social participation, then intersectoriality, in primary health care, access to care, something to identify as barriers, and then how social determinants have been approached in PHC. So I'm going to give the floor to Maria Zorrilla from Argentina. She's a doctor. She's a specialist in family medicine. She's coordinator of the community program of the Ministry of Health of the province of Argentina, of Formosa in Argentina. She's in charge of ecosystem health, and she's been working in the province for over 20 years. You have some publications in the team about PHC and some experiences. You can, if you're interested in her experience, you can get close to her later on.
Bueno, buenas tardes.
Good afternoon, and thank you very much for this kind invitation. I would like to share with you our practical experience of a small province in Argentina called Formosa. This is a big experience in a small territory. It's big because it's already 20 years old. But one of the secrets for success was to be kept alive along the time. I'm going to show you some things now. The program is called Community Health. We celebrated 20 years last year. It was born in Formosa in the north of Argentina, limiting with Paraguay. You see it in red. As you know, Argentina is a federal country, so each province has its own government, its own provincial constitutions, and it makes its own decisions. We have 660,000 inhabitants, and there's a large cultural diversity because there's a high percentage of originary cultures which are originary from that region, and they continue living in their own communities. There are descendants from Paraguayans and from all the European settlers. Well, this wealth of ancestral and originary cultures gives a particular feature where there are multiple knowledges and languages about the care for the ecosystem and health care. Now, the experience of this program stems from a political crisis in 2001. The program was created to give out to all the province what we could in terms of care. And so in 2001, we started this program in the Human Development Ministry, which is equivalent to the Ministry of Health. The purpose is to strengthen some of the premises, intersectoral integration of knowledge, solidarity. The general purpose is to promote healthy habits, to value the knowledge of local communities, and to integrate other therapies to the healthcare system. We are all in this community ecosystem and the sum total of knowledge. The person coordinating this program is Julio Gonzalez. You know, some of you know them. He was a healthcare doctor, has master in primary healthcare, and everything that he learned living with the communities were shared in the program, and he went on strengthening that knowledge that people living in those territories have. So who can participate in the activities of the program? Well, the multidisciplinary team of community health. We have psychologists, doctors, nurses, sociologists. The educational community as well, because we have activities in primary, secondary schools and universities. and we coordinate all this with the Ministry of Education in Formosa. We also coordinate with the Ministry of Human Development, working together with us, particularly where they are interested in certain activities in healthcare centers at primary level. And also in rural communities, we have all the neighbors participating from Formosa capital city in the rural communities and also indigenous communities. The main goal of all the activities of the program is to recognize and value local knowledge to promote comprehensive health. And this involves not only the health of human beings, but also the health of the entire ecosystem, water, air, food, what happens with our relations, because the health of our relations is like the fuel for the activities in the program. So the health of relations with our parents, with the animals around us, with all the living creatures around us. So the program hosts community meetings, and those are times and spaces to share all this knowledge and all this self-management practice for healthcare. These are practices that the community shares and doesn't need anyone from the outside to continue with those practices. We can learn some recipes for healthy food, and so we share it in the community. And they can enrich that recipe and do other recipes to improve food in their communities. We also share knowledge about plants and medicinal herb or digital puncture, massage, community massage is what we call them, to take care of our health. We learn about recycling of waste, taking care of water and air, water in the air, and what the community needs is what we do. The program may propose something if they haven't told us what's happening in the community or why is it that they want that. And then once there, we can make a diagnosis of which the needs are and what that community is enthusiastic or excited about. So we may think that we're going to do some plant preparations, but the community has some addiction problems and they need to work on that. Or they may need to work on comprehensive sexual education. So next time we meet, we would bring up that topic. We also have a strategy for popular education. Knowledge is generated among everyone. And in these community meetings, we all form part of the community. It's not that a professional would come up and tell them what to do. We all meet together and we share our knowledge as professionals in that meeting. We form part of the community, and so we are on an equal standing. Another strategy is the Club for Healthcare, particularly in primary schools with boys and girls, where they would state a project that they would like to carry out to look after the ecosystem or health, and so we would accompany them. There are also young people for health promotion. We work with the teenagers and secondary schools and to build knowledge about comprehensive sexual education. And also the course on community multipliers. It's open to all those who would like to share ways of taking care of life in a comprehensive, holistic, and natural way. It must be environmentally friendly. They may attend the course and then share knowledge in their community. This was a strategy in the program to be able to expand to the entire province. So we have this course so that we can train people and then convey that meaning to their communities. The results and achievements, well, the ones I've noted down are the sustainable participation of the program, because of the time it has been in place, 21 years. There are long processes coming down. There are communities that have been with us since its very beginning. So 20-year processes. And they have transformed because everything is dynamic, as the previous presentations said. And so you have to be very flexible to be able to adapt to those situations. We work in networks and in intersectoral networks. The flexibility to plan and execute what we're going to do. Another achievement was that once we highlighted the local knowledge about medicinal plants, the ministry can prepare technical standards to prepare phytopharmaceuticals. We did this together with chemists, and so we could create some technical standards. It's like prescriptions, so that you can do and prepare those things at home. If you follow the rules, you know that you'll be able to carry them out and without any risk of intoxication. So that was another achievement. Then we had over 2,000 people being trained in our courses, over 30 provincial places and 15 provinces where the activity has carried out or is carrying out activities sporadically, and a strong knowledge of the territory, adapting methodologies that are respectful of the uniqueness of each community and territory. And to conclude, well, the social participation is in synergy with other social movements in Argentina and in the region. It calls for the model of civilization model because there is a crisis where we are in. Particularly, we've seen this during the pandemic. To undertake participation right at this time is a possibility of changing the social paradigm, that is to strengthen the capacity of being there. What Julio Monsalvo showed us is that we have to change the anthropocentric paradigm of healthcare at present to the biocentric paradigm, where life is at the center, looking after life and as a comprehensive way is the key for this community health program. This QR takes you to a 9-minute video where you can see the activities that we've been carried out for 20 years. And I've also have some brochures if you would like to take them home. Thank you very much.
Gracias, María.
Thank you, Maria. I know the time is short for so much to tell, but also we've seen here a strategy in the community and the social participation, which is based on communal knowledge and local knowledge. So it's not only understanding people's health problems, but understanding those people and understanding their context to design better intervention and actions and a collaborative work, and the role that they have in developing solutions. I think that's essential. Now we're going to hear the second presentation. We're going to invite Adolfo Alvarez from Cuba. He is a physician and specialist in public health, and he's a researcher in the Epidemiology Center in La Habana, the secretary of the National Research Program on Social Determinants in Cuba, and the coordinator of a work group on social determinants. He's going to tell us a little bit about a process which is taking place in Cuba and some of the changes that they've seen in the last few years. He's also brought us a book called Social Determinants of Health, a 20-year ontology, and so anyone interested can speak with Adolfo. Good afternoon. Firstly, I want to thank Gabriel for the opportunity and the organizers of this forum for allowing us to share with you a group of experiences which have been carried out by the Institute of Hygiene in Cuba. and the sectorial program in research in social determinants. We want to begin with 4 points which somehow justify, excuse my voice, I've been slightly unwell. But firstly, we want to determine that after the government established this issue of social determinants of healthcare, is that attending to disequalities and inequalities in the healthcare should be a priority in Cuba. And it is a priority for this year's in Cuba. And secondly, social inequalities and the number of people who live in conditions of vulnerability has risen in the last few years as due to certain different factors. This isn't something new, it's something that began and was identified by the government in 2002 when it was this study group was formed of social determinants. Thirdly, today there is more than 1,000 community and nearly 20,000 families who receive some sort of protection on behalf of the Cuban state, although not all of them are identified, and we've been working on this with a social determinants focus. And then finally, in the last few years, we have worked on a revision and updating the program of this family medicine program, and trying to recover the foundational principles that are based and for the strategy of primary healthcare for Cuba. And why do we say this? Because considering these conceptual elements that we've said more than once, we can ask ourselves, how can we contribute to strengthen primary healthcare in Cuba with a focus on social determinants? And it's this process of updating and renovation of the program of family medicine. We reviewed at least 5 elements or 5 routes of action which we could contribute to developing this issue. Firstly, we need to decentralize, and this is part of the actions that we traditionally do and are traditionally done by a healthcare team. Secondly is the technology. It's analysing the healthcare situation. Up to now, it had been done with a limited focus And then third point is, how can we develop a family health record? And this was an important initiative during the pandemic. And then we also have healthcare surveillance. And in this case, it's a monitoring program of social determinants. And to do all of this, you need 4 elements which are clearly established, and in our model and in the book it has been described. We have identified the 4 pillars for the social determinants of healthcare in Cuba. Firstly, local governance, or a political action. Then we have community involvement, social determinants, and we can't go into detail for all of these, but we can talk about this afterwards. So how, considering this indication, the Ministry of Health, we began to strengthen these technologies which are involved in the family medicine program, and we found that after COVID, and it's been said many times, we had many negative elements, but also some positive things. And one of these positive elements that was worked on during for some time is the proposal of having a governance model which is based on science and innovation. And during COVID, we definitely had an important role. A second area is what has been named, or has been built on how the Ministry of Healthcare is based on this system of governments, and it's a strategy for the management based on science and innovation. And of course, this strategy for management of the healthcare system, it also had an observatory, and many actors and participants would report to. However, when this was planned, we had the meetings, somehow it was already quite established, and it was already a surveillance system and monitoring system, and we've been doing that since the meeting in Bogota. So one of the important elements in this monitoring system is what are the sources of information which are trustworthy and validating, that allow us to integrate, analyze, and generate proposals which feed back and influence decision making. So another important element is how this it wasn't done in an individual and separate way, but rather it is done throughout the country, and so that is a strategy of the movements of the communities, as we have seen. And we have managed to generate a joint effort, and each of these proposals contributes to these proposals. But also, this is summed up in a national program for research in social determinants, and it's a priority for the country, and it was assigned to our institute for us to develop it. So here are the main sources of information that allow us to guide the monitoring of the social determinant. We may have already mentioned some of them, and I believe that it is important, we will see this afterwards, but here you have this first point. This is a proposal of a guideline for analyzing healthcare situations in a community by the primary healthcare team and with the community. And then it was a situational analysis on more sectors, a sectorial analysis at a level of the healthcare centers, of the community and the provinces and the country, and you introduce the focus from social determinants. As you can see, there's a perception of social determinants and the differential expression, and that was a tool that was called Determíname. And in this initiative, we developed a tool, an informatic tool, which allows you to develop certain radial graphs from which you can identify in the community based on the block and the community, the area, the neighborhood, and a basic group or healthcare center or whatever group you want to analyze on what are the factors and the conditions which are affected or are negatively impacting that community's or that population's healthcare and health. And so first you can see the different perspectives. And then we added a second questionnaire which is directed at the evaluation and the compliance with public health recommendations, and to why or why not they are failing, and some of those conditions may be involved. And then we incorporated a third questionnaire, and it evaluates the satisfaction of the population for the services they receive in the clinic and in the doctor's office. And this allows you to develop certain responses which can have room for improvement, and this way we can contribute to the population's health. We were already developing this when we went to Bogota. After developing this tool, we identified 7 inequality axes which had a possibility for intersectorial work and inequalities on a country level. And what did we do after this? We saw that those axes of inequalities, we incorporated another questionnaire, which you can see here, in which we evaluate the characteristics of those who are giving the information to see what correlation there is between the inequality axes and the perceptions of the population. This coming to the end of my talk is some of the evidence of this monitoring system that we have in Cuba. It is the elaboration. Here it's an example of a rural community, perhaps one of the lowest underdeveloped programs, but this began on a blackboard in COVID, but it allowed us to develop a whole system based on the principal social determinants of health, and there at the end you can see something which are macro programs that can be returned to the government. All this information is generated from global and national censuses and surveys which are done by other institutions, and they may not be using the program, but they can also contribute to the observatory. And so this has allowed us to we can't just identify those. And this same iceberg that was used in another session, in this same iceberg you can see how we discuss each of these spaces, the shared responsibility, social shared responsibility for healthcare. And this is my last slide. Science is the transformative axis for primary healthcare.
We've given voice and participation to the basic teams and taken into account their experience, even if it was a very small one, through municipal and provincial and national meetings of family medicine, that's the way they were called, to share the main results so far. This year, just a week ago, we held the 3rd Congress of Family Medicine in Cuba. We held a symposium about health determinants where the best experiences in this topic were discussed. And let me conclude with 4 elements. The factors present in the life of population, particularly social inequalities, produce important effects. We all know that, but this is verified in Cuba. And these inequalities are seen in the territories and inside the territories. In the second place, there is enough evidence to adopt social determinants in our country. This approach results in theory to the practice in healthcare and the decision-making process. We want to include this approach to public health care and something else. Funding of PHC should not be in just ensuring medical services. It must also include the collective discussion of knowledge and practice, all those elements that determine it socially. Francisco Rojas Ochoa, Professor Ochoa, very well known in our country, said in 2004, he said that the 21st century is the century where solutions would stem from official science. I think that in these 2 days that we've been working together, we have heard Professor Rojas Ochoa's. Thank you, and I'm sorry if I've taken too long.
Muchas gracias, Adolfo.
Thank you, Adolfo. I know that time is short, And going back to our definition of territory, we can build the reality of the social determinants and their impact, and how we can make progress in spite of limited resources. Technology can facilitate this process, and there are challenges involved. I would like to move on to our following presentation. Jenny Rubio Orjuela from Colombia, but she's been living in Chile for over 8 years. She's an occupational therapist, and she works in Santiago. She was the sub-director of the health and community health of Father Pierre Dubois. At present, she is a technical advisor to the health department of the community in charge of implementing health focused on people and also the adolescent cycle. She holds a postgraduate degree in community mental health promotion. So, Jenny, you can have the floor so you can share with us your experience.
Muy buenas.
Good afternoon. Thank you for this invitation. I'd like to share an experience in Chile, a development model in community health based on assets for health within the framework of comprehensive healthcare model in a community called Aguirre Cerro. Pedro Aguirre Cerro is a small community of 9.7 kilometers. It's in the metropolitan area of Santiago in the south of the city. Its population is enrolled and validated in the public health service to cater for 10,500 people. The projection of the population is 105,438 people. This community is characterized by some social and economic indicators showing a vulnerability context, which isn't a minor one. It is below the indicators of the metropolitan area in the country. What we can analyze here is that this vulnerability context let us see that there are territories where there is unrest, diseases, which show us a new way of looking at territories as asset-based. As a contextual framework in this family model, family healthcare model, starts with a strategy that does away with the way healthcare has been provided to families and communities, looking into three unwaverable principles: individual focus, the continuity of healthcare, and comprehensiveness. Right from the outset, there is a new way of providing healthcare, trying to do away with the pathologization of life and to see people in their territorial context. Our idea and the strategy conceives a model with their two main axes, which is the risk stratification. We stratify the population, that is, we have a population approach and several alternatives trying to modify healthcare. And in all these measures, we can propose the development and relate the community on these assets for people and for the territory. The question is how we can look at the territory in a different way from the traditional outlook in PHC, which shows this has to be more assistential, healthcare affairs, and also open up boxes to provide service. But it also takes into account how to relate that healthcare service in the boxes and do work in community health. So the strategy is how to see this way of working, which is new. As many of the presenters have said, this has to do with the crisis that Chile, social crisis that Chile went through, and also what the pandemic has brought about. There are some kinds of not only health gaps, but also social gaps that prevented us from getting to the territory. And so that crisis shows how to approach the territory, which is not based on diseases and pathogens, but on health. We clinicians have to look at the territory from the standpoint of strengths and wealth, and the territory as a territory to make a transformation in healthcare. People talk about community health, but the question is how to do it from differently from what it used to be, so that there are preventive and group educational teams that can go beyond the work that is focused on certain issues, and how to make the collective dimension operational. And this has to do with the way we can recover that added value of social capital that the population has, that neighborhoods have, the dynamics that healthcare teams don't know, but thanks to the pandemic, they started coming out. I would say we didn't know about those movements, and they became more important over the pandemic. So this gives a new meaning to the healthcare for the community. On the basis of that process, we have a process whereby we call all the institutions of the municipality, with a strong stress on recognizing all the agents in the communities that we all know. And this is very clearly stated in how, as from popular soup kitchens or solidarity during the pandemic, we start recognizing community assets that are developing healthcare processes in the territory. And so the healthcare team turned around and could see that there is not only health coming from the healthcare centers, but that there are social dynamic processes that state deep changes. So implementation starts in 2019 with some initiatives formed by three-party members, where you have the academia, experts, the intersectoral, the police, the firemen, municipality, and the community, and they start discussing how to face problems in a different way from the vertical way that was used until then. And there we start looking at things differently. So there we can see that we could have a training course for community agents. And that has worked out very well, because everybody agreed that that was the solution for this issue. And what they did during the pandemic was wonderful because they went out to accompany people who were on their own, who weren't feeling well, who didn't have any support networks. And so the intersectoral management was absolutely different. You know, instead of having everyone doing their own work according to their plans. And so the idea was to look into new challenges. In 2021, we made our first map of community assets. We held the first literacy health workshop with a different outlook. And this workshop was a way of making our first training course in leaders to promote life. We did this with the University of Chile. It's a 3-month training course, and the practice is to make the first map to identify community assets of this community in particular. That was our first pocket guidance of community assets, and we are using it to prescribe health. I know that many experts that don't like this question of prescription of asset recommendation, this is what the community did, and it's useful for the healthcare team to see the individual in their family context, and that not all family problems are solved through the technical, clinical technologies. We also had our first manual for community asset management, and also we have implemented self-management workshop not only for healthy food but in awareness, so that those who are included in this strategy, they go out and cook. They cook in community with their families and their neighbors, and they learn new ways of looking at things from their chronic situations which don't come from the hegemonic power. So as a result, we can see a cultural transformation of care.
And there is a totalization of the care and in the care of these people in their own territories. And we see these territories as a place of knowledge, and mapping out the territory, understanding the richness that one can find there. That has been an important advancement for us because it shows us what were current knowledges that outside traditional knowledge sources. And also there is a rupture with clinical biomedical practices, and we have new ways of teaching people to see how a world from a different perspective, understanding that each person has their own life and in the territory. Of course, we have an intersectorial management based on this health perspective, and it's been developed in a community assets, and we've been working with young people and children and focusing on active growth. We've been investing in social capital training of people's families and communities. We want people to be we know they have capacities for managing the territory. We want to train teams that are feeling and thinking regarding their and their participation is also very important in social prescription, because this has been something which it's been giving very positive results. I think what I can summarize is that my recommendation and my greatest takeaway is that co-producing alongside with territory agents to produce health. Give them the power. Help them to manage in a different way from the power that they already have to improve and maintain their healthcare. Thank you.
Bueno, muchas gracias.
Thank you, Jenny. Time is short. And now we have the last presentation, not the least, but we have with us Norma Cruz. She is from Peru. She's an obstetrician. She works in Regional Indigenous Peoples Health Coordinator, and she is specializing in governance, interculturality, and public health, and is going to share her experience in this area. Good afternoon, everyone. Firstly, I want to thank the great opportunity of being with you and share the experiences that we are each doing in our countries, thanks to this forum and the organizers like WHO and PAHO for doing this, making this possible. My name is Norma Cruz, and I currently form part of a technical team and decision maker in region in Peru. In this opportunity, we are going to share our experiences that we've been developing in an intersectorial manner to manage or propose solutions and problems that have been prioritized in our regions. It's not necessarily successful experiences. This is a change experience which is going to be shared with you. The Amazon is a department in the region which is in northeast of the country. It borders with Ecuador. We have 500,000 people, inhabitants, and you think it's all the Amazon jungle, but no, in the south we also have hills and mountains, and 2 provinces with valleys and a very tall mountain in the one area. And that is where you can see the red, the area where we have indigenous people. We have Wambis and Amahu people. When we talk about indicators, healthcare indicators, which are above national one, we have higher poverty levels indicators. Also is the Human Development Index, one of our development indexes of life expectancy is at 74 years of age, and if this is extrapolated to the north, in indigenous people, we don't have elderly population, so the life expectancy is lower. Actually, this malnutrition is higher, and maternal mortality is also higher, and it's our region which, after COVID, this population had no healthcare. We have a high index of infant and maternal mortality. Actually, we have many teenage pregnancies and many pregnant women with HIV, and this is at 13.8% of all the women, which are currently attended by the Ministry of Health service providers in the country. And also the incidence of HIV is on the rise in this territory, in our original peoples. And these factors are highly influenced by education and the evaluation of reading abilities in this community, and mathematical abilities are very low in these communities. And so here you can see as reading comprehension is at around 16%, and maths is 10% of these children and this population. These are some indicators, regional indicators, which show the indicators were mainly in this indigenous people population. But what does the people, the country and this region do? We are always aiming to reach the global development, sustainable development goals. We want to promote healthcare using a community healthcare for family, and we are restructuring the whole healthcare system in which the services are providing by categories depending on distances, and it generates networks for healthcare. These are policies which enable us to comply with these goals for the country. We need to have participative and community involvement in our region. Considering the regional government, there are decision-making instances which are established for generating pacts and agreements with the local or provincial governments. These are agreements which need to be established so that there are investments for great social projects such as water, economic, roads, and other projects. So that's the regional government, which dialogues with a local government. Both of them have autonomy to govern and begin to see the different problems on certain social determinants. So in this instance, they have working groups, and an important project is working on domestic violence and certain investment in youth. On a more local level, that is where we are mostly focusing on healthcare issues. These local governments begin to give visibility to certain issues and what is mainly affecting their population and their communities. So when they are candidates, they have their government plan. That is what is going to be voted in the elections, and that should then becomes a commitment to the country, and they need to put it into practice. Regarding maternal health, we are encouraging the creation of certain infrastructures, and also they are helping with the budgeting to bring the resources that we need to generate the meetings and training programs and working groups with the different community agents, and that is part of the local government's role. Another important issue is with this visibility and understanding the problems of the population, they can demand from their governments to prioritize through a technical document to generate a kind of policy and a law. Everyone needs to be involved. Everyone needs to fulfill those agreements and commitments which are established. An example is that within this province where we have indigenous people with the rise of HIV, we can generate a policy and a new regulation to establish to try and work on that issues. So, for example, another example is when there was many manifesting against this Amazon jungle because they want to protect the jungle. After that conflict, there is dialogue between the different levels. In the Amazon, we had a new discussion prior to a new law. No one can go to a community because their community is like going into someone's house uninvited. So we are always working on giving consent and collective consent for certain interventions. This population, after these intercultural discussions, which gives visibility that young people are dying. What are they dying of? And from the healthcare system, we can tell them what their population is dying with. It's like as if we're not being truthful with them. Another factor which is determining that HIV was the cause of death among young people, and they began to make decisions, and they realized that it wasn't caused by witchcraft, but it's a healthcare problem. So these discussions are very important because they need to begin to listen to them, understand their knowledge, their stigmas, their fears, and that generates documents and then intervention plans so that every municipality, every local government, and those populations can fulfill certain projects and certain achievements. And that way we can generate new plans on a more local level. Also with maternal health, after maternal deaths, and generating new practices and organizations for generating an adequate healthcare for them. Considering this discussion table and agreement table, there was a commitment to encourage the communities to work on 4 dimensions: institutional dimension, economic dimension, productive dimension, and considering the social dimension. We also have these aspects of healthcare and education. These are the strongest indicators that need to be worked on. And we also have prioritized more than 12 indicators which are very important, related to infant healthcare, child pediatric healthcare, mental health, and it also needs to be worked on with indigenous people, and also it is involved with non-communicable diseases which are on the rise in these populations. So these agreements also need to be worked on during their period of in power. And these discussion groups want to generate improvement of the indicators, and they have to be involved and participate, because it's on their behalf. Their government could not propose solution on their own. Then we have the presence of certain social programs. We have a Ministry of Social Development. These programs aren't for everyone. They have specific goals in working with pregnant women and children to try and improve their access, vulnerable people access the healthcare providers, and also to access education. Those programs have specific budgets, they have specific interventions and accountability programs. So here for us, what's very interesting is we want to begin to establish these programs. We are discussing so that in a specific territory they can add and build on certain activities, so that resources are not badly used, but that they are actually benefiting the community. So, for example, in giving the families certain non-perishable foods, they often don't consume them, and we realize that when they take it home, it isn't eaten by the children, but the whole family. So there are certain policies that need to be considered. They need to be see if they're applicable when they are implemented in the territory.
Likewise, when we assess some programs and some interventions in education, for instance, looking at the distribution of tablets to provide each institution an educational institution, and they end up becoming toys because there is no internet access in those places. The fact of doing these things in rural areas, well, we have to take into account all those things. Then there are other players, such as churches, that are participating and being involved in health issues. COVID was one example. Many of them came up to us, which were the populations that were the latest ones to get the vaccination to protect them. When this morning you were talking about resilience, when you go up to them with a vaccine, the answer is, what do we need these vaccines for? We already have an immunity. Look here, there is a lot of mistrust when you don't serve those populations rightly. Now, in the past few years, we have somebody has been assisting us in landing these territories, these policies in the territory, and that was PAHO. That has made a difference to institutionalize the intercultural dialogue. And our research work gives us a more holistic view not only looking at prevalence or incidence values or morbid mortality in the area,
estudios en lo que
but start having in order to assess access to health. We did a very important work during COVID, and to be able, through our intercultural facilitators, to do research work. We have been able to see the availability of healthcare services, looking at the accessibility not only in the days and the time of transfer, but looking at the economic environment of families that make it impossible for them to go to healthcare centers. Economy is so deficient that not even the bananas or the yuccas that they produce can sell them, and least of all to make the decision of going to healthcare centers because of the cost. The first contact, how long does it take for a person to go to healthcare centers? And definitely when you talk about quality, there's an enormous barrier. So we are analyzing all these matters so that these results from our research work not only focus on what we do on a daily basis, can produce changes and decisions of people who are in charge of the various directorates or regional and local governments to make changes. Therefore, having a look at all these experiences, I think, well, it's good to have a plan into a government agreement, but the question is, who does it? Who looks after them? When I render accounts, do I inform about all this and about the results? Many times people come up to look for works, but not indicators or social determinant indicators. That's where the large difficulties lie, and that's where we have to work on. This is a graph showing a total imbalance. We have a segmented system in inequalities in our territories. I've seen the distribution of financial resources. We have an intercultural policy with no budget, health promotion, and comprehensive health care without any budget in order to be able to implement primary health care. So all these policies that do not land with an intercultural approach are there. We have to articulate them in the territory, and something important from planning and participation of the population in the plans and projects, the surveillance, not saying that because they never came to my population, well, and they don't see that as a right to health care for them. So here, if I'm talking about budget, sometimes cooperation can last a while, but then how can I sustain this along the time of everything that involves the experience and the work that we do? And something important, I put in goals. Sometimes we measure figures, coverage beneficiaries. Last year I did 100 beneficiaries, then next year I'll do 100 more. But I don't see articulation goals. Some of our colleagues were saying, where I can see all this in a comprehensive manner for the development and reduction of poverty when I look into social determinants. There's also a fundamental thing. If we don't develop productive aspects and economic improvements, we're not going to move forward in reducing poverty. That's why I'm saying that the distribution of resources, the interventions that we can make, must address more and more to where they are needed the most. And where is that? In the most vulnerable population, in originary population where poverty is higher. And that's where we have health and education barriers, which are very bad, without calibrating the economic conditions when costs are very high there. We were talking about internet that doesn't exist, and we want to put in technologies. Telemedicine cannot be implemented and basic services are deficient. So the commitment of a strategic and comprehensive integrations to reduce inequalities with an intercultural approach, not only for health but for all the sectors, articulating these sectors or priorities that the populations have, that must include all the various levels of the organized civil society. Thank you.
digamos, los tiempos, tratamos todo.
I'm sorry because we were pressed for time. We had a Q&A session, but perhaps those who were here until the very end can ask a question about the experiences. No questions? All right, very well. I don't know if you know whether the activities is still going on downstairs. So perhaps we can have a question. Come up front. The fact that we are few doesn't mean that it's not interesting. You can also ask questions among yourselves. We had questions for each one of you, but let me give you a question that was common to all of you. As a conclusion, we have shared experiences in the importance of territory, healthcare, social participation, and intersectorality. We've also thought about the fact that it's not possible to make programs more effective, health inequality, if we don't look into social determinants. It is within framework that I would like to ask each one of you very briefly, which are the changes and innovations that you consider are necessary in primary health care to integrate these various aspects? What part of the model must be renewed or reformulated? And try to prioritize a couple of key ideas which, on the basis of your experience and presentations, would say that those are the things that must be transformed or improved in PHC. Well, there are a couple of things that are important. One has to do with education, how doctors are trained, what's the paradigm and what's the vision. Education should be our focus. If you go to territories, if you go out to the community, how are they related? Also following this biocentric paradigm, what's important is life, and the right to health is the right to live healthy lives, and that includes the entire ecosystem. And also incentives to professionals who work on PHC, particularly economic incentives that move professionals apart from their core. But if they're badly paid, well, in Argentina we have very few or fewer physicians. I think that we have to subvert the practices of community health as we've seen traditionally. Incorporate the healthogenic approach is most important because we're focused on the damage and not looking into the entire environment. Governments should have as a priority how to land health in relation to guidelines, because there are many guidelines that are in contradiction and that do not articulate a harmonious health structure. I would say that we have to change many approaches in our interventions. Respect to intercultural approach, the training of the staff, to reduce prices because the quality
equipo básico. Y no es justo
the quality is not depending on one person, and it isn't fair that there is a big gap between multidisciplinary teams in PHC to focus on completing the human team at those levels, and if I haven't got them to do it itinerant until the conditions for the population to go to those centers is improved. And the other thing that's fundamental is to start increasing budget for health promotion actions. Very brief. I think that in these 2 days we've been able to see, and in this session in particular, that PHC interventions are not going to be sustainable if we don't introduce social determinants. Many years ago, there was an image that said we have to treat people to make them healthy, but we have forgotten about that, and we have focused on how to put more money in healthcare services. We have to work on education, not only medical education, but education of all health professionals right from the outset, and to see how health is determined so that we can have integrating access. Thank you very much. Your positions have been very firm, so thank you very much. A round of applause for you. The next session is starting right now. Thank you.
sí, al otro lado. Ya estamos agotados. Sí.